Hey guys, this is your cardiovascular guru, Dr. Akshay Sharma. This is the final video in a three-part series on acute rheumatic fever. Previously, we had discussed the pathogenesis and pathology of rheumatic fever. In this video, we will be discussing the diagnosis of acute rheumatic fever, including the ever-famous Jones criteria. Jones criteria were first given by Dr. T. Duckett Jones in the year 1944. The mnemonic for remembering Jones criteria is Jones itself. I took this mnemonic from a very important and a vital book for USMLE, the first aid. So here goes the mnemonic. J stands for joint involvement. This O looking type of heart stands for heart involvement, that is the pericarditis. N stands for the node use, that is the subcutaneous node use. E stands for erythema marginatum. And S stands for Sydenham chorea. So 5 things: joint involvement, heart involvement, subcutaneous node use, Sydenham chorea, and erythema marginatum. Now there are minor manifestations as well. They go by the mnemonic TAPE. T stands for temperature, A stands for arthralgia, whether it can be a mono or a polyarthralgia. P stands for increase in the PR interval, and E stands for ESR and CRP, that is the acute phase reactants. So minor manifestations: TAPE, temperature, arthralgia, PR interval, and ESR and CRP. Now, how do we employ these criteria for diagnosis of acute rheumatic fever? For diagnosis of acute rheumatic fever, we have to consider 2 things. One, evidence of a previous group A streptococcal infection, plus along with it Jones criteria. They have to be combined with the evidence of infection of group A streptococcus. Now, the evidence of group A streptococcal infection can be direct or indirect. Direct by a positive throat swab, or a positive rapid group A streptococcal carbohydrate antigen test, or indirectly by elevated or a rising titer of anti-streptolysin O ASO or anti-DNase B. So this gives us the evidence of group A streptococcal infection. Now this evidence has to be combined with Jones criteria to finally establish the diagnosis of acute rheumatic fever. Now these Jones criteria were revised in the year 2015, and one thing more were considered in this was to divide the population into a high risk and a low risk population. What is the low risk population? Acute rheumatic fever incidence of less than 2 per 1000 school age children, or all age rheumatic heart disease prevalence of less than or equal to 1 per 1000. Our country and the sub-Saharan African countries, they come into high risk population. So if a question comes in the NEET PG exam, we are dealing with a high risk population. The candidates who are sitting for a USMLE exam, they have to consider the ethnicity, immigration status, and the travel history of the patient. So the patient has initial episode of acute rheumatic fever. The diagnosis is established by 2 major or 1 major plus 2 minor criteria. In case of recurrent acute rheumatic fever, 2 major or 1 major plus 2 minor criteria. This is the same as initial ARF. Or in acute rheumatic fever that is recurrent, we can consider 3 minor as well. So this is how we diagnose acute rheumatic fever, and this is how we employ the Jones and the revised Jones criteria. Now, the major manifestation in modified Jones criteria which were given in 2015 in moderate and high risk patients, that is in a moderate and high risk population, that is our population. The carditis, this can be clinical or subclinical. Arthritis, this can be mono or polyarthritis, or this can be polyarthralgia. when other causes of joint involvement have been ruled out. Arthritis is objective evidence of joint involvement like tenderness, redness and swelling of the joint. Arthralgia simply means joint pain. So in high risk population, polyarthralgia is considered as a major criteria. There might not be a objective evidence of joint involvement like redness, swelling, tenderness. Simply polyarthralgia in high risk patients, high risk population will be considered in a major criteria. The other three are chorea, edema marginatum and subcutaneous node use. Now, similarly, in the low risk population, what is the difference between revised Jones criteria in high risk and low risk population? Single difference. In the arthritis section, there is only polyarthritis in the low risk population. Monoarthritis or polyarthralgia will not be considered as a major criteria in low risk population. In low risk population, we consider only polyarthritis as a major criteria. Rest, carditis, chorea, edema marginatum and subcutaneous node use remain the same. Now the minor criteria. Even if a patient has a joint pain in a single joint and the patient comes from a moderate to high risk population, this will be considered in a minor criteria. Any type of pain has to be considered into some sort of criteria. If it is polyarthralgia, monoarthritis or polyarthritis, it goes into the major criteria. If it is just single joint pain, that is a monoarthralgia, it comes under the minor criteria. Fever greater than 38 degrees Celsius or 100.4, ESR greater than 30, CRP greater than 3. Prolonged PR interval. When the rheumatic process involves the myocardium, the PR interval in the ECG is prolonged. But this will be considered as a criteria only when the carditis is not considered as a major criteria. If we are considering carditis as a major criteria, if the patient has carditis, we will consider that into the major criteria. In those cases, prolongation of PR interval will not be considered in the minor criteria. Now, minor manifestation, low risk population, polyarthralgia. We saw in the previous high risk population, monoarthralgia is minor, but in low risk population, polyarthralgia is a minor criteria. Major criteria in low risk population was polyarthritis, but polyarthralgia will be considered as a minor criteria in low risk population. A fever greater than 38.5 degrees Celsius or 101.3 degree Fahrenheit, ESR greater than 60, CRP greater than 3 and a prolonged PR interval. So these were the 2015 modified Jones criteria. Now, we had considered carditis in the second video on pathology of acute rheumatic fever. The rest 4 manifestations we will consider here. Sydenham's chorea. Long latent period after group A streptococcus infection. The latent period can be up to 6 months. It primarily involves head, darting movements of tongue are there and upper limbs. So it involves the head and the upper limbs. Mainly seen in females, and 50% of the patients who come with Sydenham's chorea have carditis as well. Joint involvement. Most common form of joint involvement in acute rheumatic fever is arthritis and involves more than one joint. Arthralgia is also considered as a major or minor criteria as per the high risk and the low risk population category. The joint involvement in acute rheumatic fever is of large joints, knee, ankle, hip and elbow. the joint involvement, the arthritis is migratory in nature. It switches from one joint to other joint within hours. It is highly responsive to NSAIDs. It quickly responds to the salicylates. The next one is the next two are the skin involvement in acute rheumatic fever. The first one is erythema marginatum. How does erythema marginatum appear? It appears like a pink macular rash. You can see this, a pink colored macular rash, centrally clear and a serpentinous spreading edge. Macular rash, centrally clear and a spreading edge. This usually is present on trunks, sometimes on limbs and never on face. Appears and disappears in front of examiner's eye. This is a evanescent type of skin lesion. The other skin lesion is subcutaneous node use. These are small painless node use present over bony prominences. It's not like it is present anywhere. It is simply present on the bony prominences, commonly associated with carditis, and it is also one of the delayed manifestations of acute rheumatic fever. So these were all the characteristics of various manifestations of acute rheumatic fever. The treatment part of acute rheumatic fever is simply supportive. You give NSAIDs for pain, the fever is controlled by antipyretics and other supportive measures. The most important part in the treatment of acute rheumatic fever is the prophylaxis, so that the rheumatic fever does not occur again in the same individual. So what are the drugs for the secondary prophylaxis of acute rheumatic fever? The best antibiotic for secondary prophylaxis of acute rheumatic fever is benzathine penicillin. Benzathine penicillin 1.2 million units to be given intramuscular every 4 weeks. For those patients who are less than 27 kilograms, the dose is 600,000 units, that is 6 lakh units of benzathine penicillin to be given intramuscular every 4 weeks. If the patient is reluctant in taking injections, then oral penicillin can be prescribed, but mind you, that is lesser effective than intramuscular benzathine penicillin. The oral penicillin which can be prescribed is penicillin V, 250 milligrams twice daily. If the patient is allergic to penicillin, then what drug we have to use? We can use erythromycin, 250 milligrams twice daily. So the best drug, best antibiotics, benzathine penicillin. For those who cannot take IM injections, it is penicillin V, and for those patients who have penicillin allergy, the drug is erythromycin. This was the third and the final video on acute rheumatic fever. The links to the first two videos are given in the description below. If this video has actually helped you in updating your knowledge, then do like the video and subscribe our channel, The Cardiovascular Guru. The slides of this video are available on my Instagram channel, Cardiovascular Guru. I'll continue to come up with more such videos on the concept of cardiovascular medicine. Till then guys, study hard and stay focused.